In our IC. In fact, there was a talk of Dr. Kamal B. Kapoor also over here. Maybe we can take in between or at the end of this. So this IC instruction course is for the phakic lens use and how to begin and what are the indications, what is the best available technique, and how to proceed and how to see the complications and how to manage them, and what are the ancillary things which has to be seen post-operatively, and early detection, and what are the new things in this phakic lens technology. So I am Purendra Bhasin from Gwalior, and with me my course, can I have my slides please? With me, my worthy, Dr. Kamal has not come. So let us begin with our IC, this one. So Phakic IOLs, learn it from the masters. And welcome to this beautiful venue, and very, very good morning to all of you. So I will be speaking on introduction and overview of Phakic IOL, and then in continuation I will go further and pre-operative planning and workup. With me, our president of AIOS, Dr. Partha Vishwas is there, which will be speaking on the correct way to do ICL and toric ICL. Dr. Maipal Sajdev will be discussing and giving light on intraoperative and early post-operative complications in phakic IOL and their management, and challenging situations of phakic IOL, and experience will be dealt by Dr. D. Ramamurthy. Experience of presbyopic phakic IOLs will be shared by Dr. Titial sir, and with me today Dr. Sudhank Bharti, Dr. S. Bharti, another master and experienced surgeon in cataract and refractive surgery. So he will be sharing his experience on long-term results and issues of phakic IOL. So we all know all these star instructors, star performance. So I will go further to our talks, and overview is that we can correct refractive errors by surgical methods or non-surgically, and we'll be focusing on surgical method, which are LASIK and cornea based, and the lens based, which is refractive lens exchange or clear lens extraction, and phakic IOL. So phakic IOL is implantation of the lens which is a biocompatible lens in front of the natural lens of the eye to correct the refractive error. And they can be angle supported, iris fixed, or the posterior chamber phakic IOLs. So we will be focusing on the posterior chamber phakic IOL here, and various designs have been developed in last almost 60, 70 years, and which were failed. And this was the design which I was discussing just now, VeriSize, which was made up of the PMMA, and but many issues like corneal decomposition and many were there. This is now out of vogue, and so various designs. At the present day, phakic IOL, which we are using behind the iris, is based on the design given by the Fedorov in 1986, which was collar button or mushroom configuration. Just to give you the insight, this is a small video of less than 50 seconds. The incision of 3.2 millimeter or 2.8 millimeter is given. Fill the chamber with viscoelastic, which should not be overfilled, and the lens is loaded, front loading system, and slowly it is pushed into the anterior chamber. And this is the spatula, lens managing spatula, and the 4 haptic or plate haptic design. The haptics are pushed behind the iris like this, and even the toric design is used, and then by any means you can remove the viscoelastic from the anterior chamber. Mind it that our crystalline lens is still there, and it is clear, and we should avoid jerky movements. So the advantages of corneal refractive procedure are that over the corneal refractive procedure is it preserves the corneal integrity. So we can do it on patients which are having thin cornea or irregular cornea, or due to some reason they have chances of ectasia post-operatively. So the cornea is not suitable, that in such cases we should do ICL, and this is a reversible procedure, and maybe due to some reason it gives us an option to reverse it, to explant it, or to exchange it. And we can correct high refractive errors, like with LASIK we can correct up to 6 to 7 or 8 diopters maximally, but here we can correct up to 18 diopters, and with some lenses we can correct up to 25, 26 diopters, or maybe we can do bioptics to correct the refractive error. And in hyperopia also, if the anatomy is suitable, then we can do it. And there is because we are not cutting the corneal nerves largely, so the chances of dry eye development are unlikely as compared to the corneal surface procedure. The anatomical advantages are there, that it is placed behind the iris, and because of this it is not visible to someone. So therefore it is gives an excellent cosmesis, like iris claw or the anterior chamber lenses. It is far from the endothelium, the chances of damage to the endothelium are not there, and it is close to the nodal point of the eye. So there is a gain in the retinal size image. So we have seen that in most of our patients there is improvement in the vision and Snellen's chart vision, and it is located in the sulcus, which has a stable location, and therefore we can do toric the correction also, and there is no fixation to the iris tissue. So this table is very important for us. So which tells us in the first this thing you see about the ICL, which is the gold standard, which comes from the Star Surgical Vision ICL, it is called now, and we can correct up from plus 10 diopters up to minus 18 diopters range, and we can also correct up to 6 diopters of cylindrical power too. So it is in post-keratoconus cases, stabilized cases also it is useful. It comes in size from 12.1, 12.6, 13.2 and 13.7. The material is very, very important, and I would like to highlight it, that it is made up of a collamer hydrophilic porcine collagen, and this is a hydroxyethyl methacrylate copolymer, which differentiates it from the rest of the lenses, which are hydrophilic acrylic lenses, and they are available in our country, in India, from various group. So the second one is from the care group, which can correct from plus 15 diopters up to minus 30 diopters. I have used up to minus 26 diopters, and with 6-7 diopters correcting cylinder. So this is comes in 10 diopters correction, and the size also can be varied from 11 millimeter to 14 millimeter in 0.25 millimeter steps. Another is from the Appasamy group, which can correct up from plus 10 diopters to minus 23 diopters, and various steps from 11.5 to 14 millimeter. And lastly is the iCryl from Biotech, which can correct from 0 diopters to 23 diopters in 0.5 diopter steps, and the size from 12 to 13.5 millimeter. All these three lenses are made up of hydrophilic acrylic material, with which the IOL is also made. So coming to the design, there are certain specific things which are special to these lenses, that it has a central vault. So central vault means, as you can see below, there is a hump or there is a convexity which is predetermined and pre-placed in the lens. So lens come like this and it remains like this. And very good morning. Another, please come here. Dr. Ramamurthy is here, our star performer. And this is a foldable lens, and this vault accommodates the convexity of our crystalline lens. So this is a foldable lens and it absorbs a UV radiation, but important thing is the sizing. So advantage of this material from the Star Surgical is that it is a polymer material and it attracts fibronectin. There is a layer of fibronectin which is formed on the surface and which repels the proteins, so there is no less chance of protein deposition on the surface, and thus polymer lens is not recognized as a foreign body and there are no deposits of material on the surface, unlike the hydrophilic acrylic material. And above all, this material has a maximum light transmittance. So another good part is that now these lenses come with the central opening of 360 micron in diameter. In previous generation lenses, and in hyperopic cases, we have to make a peripheral iridotomy. But with these lenses, newer generation lenses, we have a 360 micron diameter central opening, which maintains the natural aqueous flow around the lens, crystalline lens around this lens, and therefore it eliminates the need for iridotomies. And the perioptic ports are also of the same size, which gives us the advantage of removal of the viscoelastic material from behind the lens, and it provides a redundancy for the central optic part if it gets occluded at any time by the proteins in the aqueous, but which is very, very unlikely to happen. So this new generation ICL, which I said, which is a gold standard, it has a central optic zone of 5 to 6.5 millimeter. In the range of 0.5 to minus 14 diopters, the central zone is of 6.1 millimeter, and above it, it is of 5 millimeter optic zone. So this large size optic helps in reducing the glare in halos, and particularly during the night time, and this is especially important in young males who do the night driving. So the newer generation presbyopic variants are also available. The Evo Viva ICL, which comes from the Star Surgical, I don't have any financial interest, is based on the EDOF platform, while the Indian counterpart from Care Group is a refractive optics, and it gives an add of near add of plus 4 diopters, and you can correct the toric power also. So coming to my next part, which is in continuation, how to plan and do a pre-operative detailed workup. So indications are, we have to choose the patient who has myopia, hyperopia, astigmatism, or which is a case of stable keratoconus, and they are being used off-label in other special conditions like post-refractive surgery patient as a bioptics, post-cross-linked patient, post-keratoconus, post-keratoplasty patient, and as a piggyback lens to correct the residual refractive error, and in some cases of pediatric anisometropia, which are of very high power, maybe more than 18-20 diopters at that young age. In that cases also, in those cases also, where anatomically you find that they are their development is there, and then we can do it for the presbyopia correction. The contraindications are to be remembered, and they are very important. If they have any lens opacity, or their zonal dialysis, coloboma, or pseudo exfoliation, pigment dispersion, or there is a progressive refractive error, or if there is a pre-existing corneal endothelial dysfunction is there, or they are harboring glaucoma, or chances of glaucoma are there. Angle chamber is less than grade 2, and anterior chamber depth is also less than 2.8 millimeter, then we should avoid it. And in pregnant and nursing mothers, and other than this, corneal degenerations or dystrophy, rubeosis, iridis, uveitis, iris atrophy, coloboma, lens, retinal or macular pathology, and new vascularization of iris or the retina. In such cases, this should be avoided in any case. Prerequisites are that the age which is recommended by STAR is 21 and up to 45 years of age. We can do it early when the refraction is stable for more than 1 year. LASIK rejects cases due to high myopia, thin corneas less than 500 micron, in dry eye patients, large pupils, excessively flat or steep cornea where we cannot do the corneal surface procedure, in clear crystalline lenses, their lenses are clear, and the intolerance of contact lens or spectacles are seen, and appropriate pupil size is there, which is very important because you can face a litigation later. And there should be a minimal endothelial cell count of more than or equal to 2000, and with the age and angle size and anterior chamber depth, there is a table here. And adequate crystalline lens rise should be seen on AIOS2025-IC610-Phakic. So all these investigations are done: uncorrected and best corrected visual acuity, refraction, manifest and cycloplegic, slit lamp examination, mainly for the cornea and lens, IOP, no glaucoma, angle should remain open, corneal topography, tomography and keratometry are done, which is very important. Specular microscopy should be done. Fundus examination should be normal peripheral retina or treated by photocoagulation. Corneal, and the two important things which are specific to this procedure is the measurement of horizontal wide to wide distance and the anterior chamber depth, which should not be less than 2.8 millimeter. And this anterior chamber depth, mind it, should be from the measured from the posterior surface of the cornea. We have to measure the internal anterior chamber depth. Why the corneal topography and tomography are important? Because this gives us the cylindrical power and at the same time axis of the cylinder, and we can know the steep or flat keratometry, and it helps in ruling out progressive ectasias and cases of suspects of corneal keratoconus, and it gives internal ACD and horizontal wide to wide measurement, which is imperative to the surgical planning. Now, in keratoconus cases, topographically stable keratoconus patients can be selected, and we can operate upon them, and there should be stable scans between two visits at 6 months apart. And in cross-linked patients, the one can plan in phakic IOL in stable refraction if it is attained in last 3 consecutive visits, and there is the central cone and clear central cornea, and keratometric values are less than 52 microns. So coming to the important aspect, which is specific measurement of horizontal wide to wide, how to proceed. We should believe me, I am myself is doing, and most of us are doing with the measurement by the digital caliper, which is on the right side, which are freely available, and the company people also help you in getting it. And this is the best way of measuring horizontal wide to wide diameter. Otherwise, we can do by OpScan, Pentacam, IOL Master, UBM, vernier caliper, or various autoreflectors also now they provide us. So horizontal wide to wide image you can see on the left side, which comes on the keratometers, and the right side is the UBM, which tells us about the sulcus to sulcus diameter. So we will discuss it later. So measuring the wide to wide, which is important aspect, should be done in a supine position under the microscope in a high resolution, and from middle of the limbus to the middle of the limbus on the other side, and pre-treat the eye with an aesthetic drop. This is what it is. It's a simple digital caliper. We are measuring it, and calibrate the caliper before every use. So this is how it comes. It is very, very simple. It hardly takes two minutes. You have to counsel the patient, and this is how the surgical procedure is also done. So it is advisable to acquire the consecutive topography scans and the average wide to wide to be used for the phakic IOL calculation, diameter size calculation. It can be between 10.5 to 13.5 millimeter. Less than this, ICL is not recommended. It is recommended that automated measurement is verified manually and with calipers for appropriate sizing. The company recommends 1.1 millimeter higher when the AC depth is less than 3.5 millimeter, and 1.6 millimeter higher when the AC depth is more than 3.5 millimeter. This is for your the mental calculation. When the company is suggesting you the plan, then you can check it this way. So various studies have been done to correlate between sulcus to sulcus diameter, which is the actual place where the lens will sit, or the horizontal wide to wide. But neither clinically meaningful nor statistically significant differences is achieved, and the vault differentiates between the wide to wide measurement manually by the digital caliper or by the UBM. So therefore, sizing based on wide to wide remains the most popular and best studied technique. So why this is important? Because we get a vault of this lens over the crystalline lens. So ICL provides a vault. So the ideal sized ICL is which gives a vault of 0.25 millimeter to 0.75 millimeter. So how to check it? We can check it with the thickness of the cornea. So our thickness of cornea we can see, and then we can see the distance between the posterior surface of the ICL and the anterior surface of the crystalline lens. So if this matches, so if our average thickness of the cornea is 500 micron, so this means this, which is nearly same or slightly more, so this patient has a good vault. Very good morning, President sir, please come here. And another star performer which doesn't require any introduction here. Dr. Mahipal is also here, please come sir. And the ideal size should be between 2.25 to 0.75, which is like half the corneal thickness to 1.5 times the corneal thickness. This should be kept in mind, and on slit lamp you can easily see. And undersized ICL will cause there are high chances of anterior subcapsular cataract, and oversized ICL will lead to development of glaucoma and rise in the intraocular pressure. So this is what it is. A normal anterior, this is a vault on the left side and a low vault which is seen on the right side. And if it is below this or the lens is touching, you have to explant the lens. So we should do the pupillometry, and ideal mesopic pupil size is less than 5 or between 5 to 6 millimeter, and it should be less than that. And AIOS should also be done. It provides structural imaging of the anterior segment of the eye, and it provides accurate and repeatable values of the crystalline lens rise. And in few patients, when the crystalline lens rise is not appropriate, then the chances of development of the cataract is high, and development of glaucoma is also there. So we should check the crystalline lens rise. The angle-to-angle measurements were found to have higher reproducibility than the wide-to-wide measurement on AIOS. Some studies say like that. So UBM I have already discussed. So now I think most of us, we don't do measurement by the UPM. So I will not go into much detail. This is the kind of sheet which comes from the company, which you have to check for the power what is there, which the patient is having. On the left side, you can see there is a 11.5 with 1.5 diopter cylinder at an axis of steep axis of 10 degree. And keratometry we should check. Corneal thickness is there, and white to white we have whatever we have measured is mentioned over there. And on the right side is the lens which they are recommending, and what will be the residual expected refractive error with the after the implantation of lens. And we should check for the size of the lens, which is 12.1 millimeter in this particular case. So this is a case which has got a thin cornea, 487 and 483 on the right, although the power is less, but still better to do. And this is a high power, -9 -10.25 with the optimum thickness of the cornea, but the power is more, so it is a suitable case for ICL. Another case with the thin cornea, and the power is also more in both eyes. And this is the sheet which comes from the CARE group with the similar findings, and similar things should be seen. The advantages with the CARE group lenses, they are the smart toric lenses. So you just have to place the lens in 0-180 degree axis. So you don't have to place it you have to rotate it to one side 10 degree, this side, that side, which is the plan which will be given in the toric IOL platform. But these are smart toric lenses. So, coming to the conclusion, this is the most important slide which tells us the 8 years old result, and this was published in 2021, recent this. And they say with the newer centraflow or with the central opening ICL and with the moderate to high metropia, in 8 years, there is no change in the refractive error, no development of cataract, no change in the power, and the vision remains stable. So this is what just gives you a glimpse for the beginner who are apprehensive of starting the practice of phakic lens. To conclude, no, it's a technique which involves no blood, no pain, no hospitalization. It provides excellent cosmesis, correction of wide range of myopia, hypermetropia, and astigmatism. It's reversible. Just like LASIK, it takes 5 to 10 minutes in experienced hands. The quality of vision is usually better, and induced astigmatism is minimum. We get adequate tear film and no minimum chances of development of dry eye, reduced risk of optical distortion, rather we get a better quality vision post ICL, less risk of glare halos or double vision, preserves accommodation and contrast sensitivity, very stable over time with no regression. But the important things to be kept in mind is the important thing is that pre-operative planning and workup is very, very important, and sizing related dilemmas and issues are always there, and it should be kept in mind. And with the improvements in material and design, the rate of complications have significantly reduced. Development of cataract post centraflow lenses have decreased markedly, and even with 0.25 millimeter vault, we have seen that there is no development of or minimal development of cataract. The possibility of complications and the benefits have to be weighed in each case individually, and patients should be informed about the options available before finalizing on the preferred surgical treatment options. I thank you for your patience, Harry. We will take questions at the end. Thank you all. Dr. Partha. I will introduce Dr. Partha, and he is the star performer, and we all have experience of more than 18, 19 years, and I think Partha must be having experience of 20, 25 years of these lenses. So he doesn't require any introduction. He will be speaking on the right and appropriate technique of ICL.
This is the first presidential lecture.
Yeah. Absolutely. Sir, good morning.
Good morning, very good morning to every one of you. So let us make this course a very interactive course and something that is practical, something that every one of us can learn from each other. And I would really request people who are not doing ICLs or IPCL or the phakic IOLs very much would like to answer all basic questions as well. So let us start from basics, let us go on to the more appropriate techniques, designs, and there are so many phakic IOLs in the market today. Of course, ICL as of today has the longest track record, which does not mean that the others with a lower track record are not as good. So you need to assess, you need to understand, you need to do it the right way, and that's what I'll be speaking about now. So the right way to do the ICL, and we all have a track record of quite a long years of doing ICL. And ICL and toric ICL. So let's go to the basics. These are foldable phakic lenses, which are very, very thin, which means that you have to be very particular when you are loading the lens. And I'm going to show you videos of the loading of the lens. They are supposed to be in the posterior chamber, the sulcus, and that is where they have to be posted atraumatically. The Colama material, though it looks very thin, very flimsy at times, but actually it is a very tough material. So, but again, there is a limit for the toughness of the material also. And there are instances where the loading has not been done properly, where the ICL can tear. And that absolutely is because of the inappropriate loading by either the assistant or by the doctor. So it's important that we load the lens in the right way and get things right done. So if it is loaded in the right way, most of it will be very good. Now, do we believe in the quality? Yes, we do believe in the quality. It is excellent biocompatibility. And over all these years, there is absolutely no reaction of a foreign body in the eye. And that is one of the oft-asked questions by patients that, doctor, you're implanting something foreign, so will it have a reaction? The other thing that I must say, that there are certain sections of our society who ask, is it a vegetarian lens or a non-vegetarian lens? So this is actually yes, porcine material. So you have to be, again, truthful. And it's important that you say that if such a question is asked. But what I do in the clinical practice, I ask them that do go onto the website, look into everything. So if they can mark out the porcine material, it's fine. If they don't, it's all right.
Indian lenses are not.
Yeah. So the Indian lenses are not, are vegetarian lenses. So, so about the quality of these lenses, excellent quality, very flexible, and the flexibility is one of the most important things in these lenses, and they go into the posterior chamber, which is the actual concept behind the iris, far from the endothelium. Why I'm repeating these things is because you need to be very, very confident that it is a good lens, it goes into the right place, and it will stay forever until, of course, it's explanted for reasons that are required for. So it's far from the endothelium, and you don't need to coat the endothelium with high molecular weight, viscoelastic, methyl cellulose is fine. Sodium hyaluronate is used because of the importance of getting the sodium hyaluronate out very fast and in a bolus. So sodium hyaluronate is also a substance, a viscoelastic, that can be used. Now, it gives excellent cosmesis. You can hardly make out. Of course, if someone is looking through the slit lamp, obviously the central flow, the opening is definitely visible, and it's close to the nodal point of the eye. There's a gain in this retinal image size, which we all understand from physiology, and the gain actually gives in these very high diopter segments, say 13, 14, 15, 16, 17, even 20s, it gives you the importance that the size becomes better for the patient, and the patient actually can improve by a line or line and a half. So it is very effective. The sulcus is a very stable location, easily removable, exchangeable. Again, I must say here that while you're looking at the slit lamp, please look at the slit lamp with dilated pupils as well. Why? Because there can be a small area of subluxation or zonular dialysis that might be missed. And these patients, definitely, if there is even a small part where there is a little bit of dialysis, definitely not to place in these ICLs. So, of course, there are no fixation issues to the iris, and it does not alter the shape or the tissue at all. So, the myopia and the myopic astigmatism, we have a timer now. So, now, over the years, these spherical powers, as well as the optical diameter, the haptic thickness, and the overall height. What is very important while assessing is the importance of having a correct vault. That is first and foremost in our minds. So whenever we look at the patient the next day, the vaulting should be correct, and that's why we have to be very careful of all the dimensions that we place in and ask for the lens whenever it is ordered for. So the V4C design has a central port, and it's a very, very important designing that has come in and has stayed in the practice, and all the Indian lenses also have the same. So, of course, the prerequisites, you have to be very careful. Crystalline lens has to be clear. So if there is a PSC, a small one, even a small one, it is your prerogative to tell the patient that there is a small amount of posterior subcapsular cataract, which can happen in high myopes, and it is your choice whether you should go in, because at times these just small specks of opacity that are there in the posterior capsule will not progress, but they can, and if they do, and if it is a PSC and becomes dense, then you have to explant it quite early. So it's very important that you tell the patient, you discuss it with it, and everything said and done, you have to take the decision. So the refractive error has to be stable, and this is very, very important. 6 months, we adhere to 100%. Let us remember that these are very high myopes. Even at 20, 21, there might be a change in the crystalline, in the change in the dioptric error. And we definitely do not do excimer laser surgery or laser refractive procedure for patients who are now above 8 or 9. Maximum we stretch it to 9, but the more important is a phakic IOL has become such a stable and a strong IOL that we can actually place it in even the smaller diopters. So the prerequisites, 3.2, 2.8, 2.8 millimeters we have to adhere to. Endothelial cell count we definitely need to see. The ocular examination is very important, contact lens discontinuation, the anterior segment evaluation, the measures, and the angle as well as the white to white is very, very important. So again, a word about the white to white. And it is important that we measure it with the caliper and read the caliper, but also the IOL master, which actually underreads it. So we have to be very sure that both the eyes have similar readings, number one, and there is a difference of 0.5 millimeters approximately from the IOL master reading to the caliper reading, and the caliper reading is what is taken. The anterior chamber depth is also very important. Sizing provided by the OBSCAN is again very important, but the OBSCAN is very few in the market today, and we have to rely on the IOL master and the caliper readings. So we have to avoid undersizing or oversizing, and I'm coming over to the technique of the placing in the toric ICL preparation is important. You have to mark it well, and if you have a markerless system in place, that is even better. Now just let us look at this video and the loading of the ICL. So the important steps here are filling it with the viscoelastic, and this has to be methyl cellulose, not sodium hyaluronate at all. And it's best that you fill it yourself. And it has to be half filled with methyl cellulose, half filled with, I'll take 2 minutes. Methyl cellulose and BSS. So the ICL comes housed in the BSS, so you just have to take it out like that. Be very careful because, again, they do not supply you with an extra ICL. Now, placing it on the hub, again, is very important, and this technique is very important. You have to quickly put it into the hub and squeeze it in so that it forms a hump into the hub and it sits nicely in place. If you wait too long, it becomes a little stiff, and if it is dehydrated. So placing it in, and the wings should flange out a little. And this is, again, important. This is called the osdeor forceps, by which you are actually pulling it in. So the movement should be both. You should pull out the hub, and you should pull in the lens. So then it becomes a very, very nice and a flexible way of doing it. So placing it into the hub, and whenever it is a 12.6 or 13.2 lens, then you have to be careful that the whole lens is there in the nozzle. Then, of course, seeing that it is all done under topical anesthesia, so you have to be, again, careful with the patient, and good cooperation of the patient has to be there. So inserting the lens, now both the side ports have to be made, viscoelastic has to go in, and the manipulation at the periphery has to be very, very gentle. So the body of the ICL must not be manipulated, and it is the haptics actually. So side ports done, viscoelastic, the stream of viscoelastic again is important. So what is said is the stream should be just that it starts coalescing. So that is the optimal amount of viscoelastic inside. So when that has happened, so then you make the main port. For beginners, I would definitely say 3.2 is the desired one. And here again, it is very important to see the ICL when it is coming out, because it is this time, and you have to atraumatically hold the side port very well. And then you have to see that you can see that it is folding with the hole on the right. So forward and right, that's how it should unfold. And once it unfolds the right way, then it just gently slips in. And so it's the leading right in this, whereas in the IPCL, it is the leading left. And there's a notch in the IPCL. There are no notches here. Now, placing in the haptic into the sulcus, again, is very important. Again, very atraumatically needs to be done. Viscoelastic on top, but not to overfill. If you overfill, it stretches too much. So just the optimal fill, and then just tweak it in. So that's very important. All these maneuvers have to be done very, very gently, remembering the fact that the zonules are there, very strong, but at times they can give way also. So placing all the haptics inside, and then checking if it is a toric ICL, that the axis is in the right place. Now, we still have to do PIs if it is a hyperopic ICL. We don't do PIs whenever it is a V4C. And the centration should be good. The post-operative results are usually very good. Glare and halos, if patient complains, just let time go for neuroadaptation for that. Usually they adapt very well. The IOP check has to be done. There can be IOP elevation and the ICL vault. So we'll just stop at this. Thank you very much for your patient hearing.
Thank you. Dr. Partha. I think if we can have Dr. Maipal now, intraoperative and early post-operative, please. And then we will come to the challenging situation. Or if you want, you can go ahead. It is in the other way, but because the sequence, this is
early has to come before.
So we can, please, you can keep the questions for the end.
Let us quickly ask one small question. How many of us are doing ICLs? Just one or two, maybe. Two hands go up with Kamal.
Half of them are not doing it.
He does both.
So,
And with both hands. No, what I would really suggest that, though some of the lectures could be a little on the higher side and rarer complications, management and all that, but please do feel free to ask very basic questions also. So when to choose a patient, how to counsel a patient is again a very important thing, because here counseling is one of the key things. And I think counseling issues are such that patients come prepared for laser refractive procedure, and you understand that it is not possible, then you have to put it into the phakic IOL category, which becomes a difficult proposition. However, please give chair time, please answer all questions, please tell very safe procedure, and then the patient gets convinced.
Thank you. ठीक है? Okay. Thanks, Purendra, for having me in the course. The history for the ICL is about 30 years old. That's when the first ICL was implanted, and I have been actually the first phakic lens that I implanted was a PRL. That's a PRL, that's a phakic by SIBA. That's since been withdrawn from the market because there were reports of zonular, it cutting through the zonule and going into the vitreous. But this ICL, I've been, 1999 was the first ICL that I implanted. As Partha left, he put in the implant. The post-op management is steroids and antibiotic drops, and also to lower the intraocular pressure. In the immediate post-operative period, these are the things that have to be evaluated. What is the visual acuity of the patient? I don't promise or say anything to the patient, but since we are dealing mostly with high myopes, and because of the elimination of the minification factor of the glasses, they normally tend to gain one line of vision. So if you're doing a -14 or a -16, so if the BCVA with glasses is 6-9 parts or something, so he or she may end up with 6-6, and that's something like a bonus which you have. Slit lamp examination is obviously important to rule out any corneal inflammation. IOP pressure, vault measurement is something important. The preferable vault is about 350 to 700, so that's the preferable vault, but patients can survive without getting cataracts or pressure problems, even if the vault is maybe more or less than this. The ICL centration and positioning is important. If you get a cross cylinder, or if you get a mixed astigmatism, that means that if you're on the AR, you're getting a plus or a minus, understand that that means that the cylinder is not in the proper axis, and you need to dilate the patient and look at the positioning of the implant. So this is just to show you a good vault. You can compare it with the thickness of the cornea and see as to where it is, and this is post-operatively. You can see this is where the cylinder should be, and this is what you can see there. Now the complications or the problems that you can have is that pre-operative there could be an incorrect workup, and therefore the size or the power could be different from what you wanted. Intraoperative, I'll just show you that you could be actually implanting the ICL upside down, and that's going to be disastrous. Post-operatively, incorrect axis of placement, cataract formation or glaucoma can happen early. Low vault, early cataract formation, and toric ICL rotation. That means that if the lens is small, it will tend to rotate. Now this is classically before we had the V4. The hole has another specific purpose, that you can use it to aspirate out the viscoelastic. Use that to aspirate or flow out the viscoelastic from the center. This is a typical cataract that develops very, very early if you are leaving behind viscoelastic in just below the lens, because it's very difficult to go below the lens and aspirate it out. So therefore you use the hole for pushing fluid so that the central portion is clear, or using it to aspirate. This is a case of cataract. You can see we are using a femtolaser to kind of take out. So you can see the vault is good. This is the pupil. The problem here is that the pupil is the optic zone is taken up as the pupil. So therefore you have to enlarge the pupil. And once you have enlarged the pupil, you get an excellent capsulotomy with this. So you can see here that there is an excellent capsulotomy that you have. I think this is one of the least of the problems or the complications, because doing a cataract surgery, IOL power calculation is not an issue, because the lens is very thin and you don't have to put any formulas, and you can take out the cataract pretty easily. So this is just to show you that the lens can be pulled out from the same incision. You don't have a hand-over-hand technique is what is required. Now this is a case came to me, had been operated somewhere in the NCR, and the ICL was kind of subluxated. Patient was not getting good vision, and you can see in this particular case, the lens is, can you see this? It's, and the doctor had redialed, and there was also this cataract formation which was there. So you can see I did the OCT, the vault is pretty good. He had used a 13 millimeter lens, but despite that, according to me, it should have been 12.6, but despite that, I couldn't find anything on the OCT. The UBM also didn't. So these are surprises. This is one of the surprises I have seen in my career, that despite the size being all right, the lens was getting decentered. So so this guy was terrible. I'm sure he'll go to the consumer court the way he was talking. But I told him everything is good. There is no reason I can find out as to why this has happened. But there is no other way that you can do in this particular case. But if it is there in the early, redialing has been done early, this thing, you have to just pull it out. And ICL is much easier to pull out than the Indian lenses, because the material is different, but you still use a hand-over-hand technique and you can pull it out. So you'll have to get this down now. This patient is phakic. I will do a partial reduction of his power by doing a LASIK on top of it. Early post-op period, you can see that this is where on the Varion, this is the ICL where it is, and this is where it should be. So you can go back and actually redial. You don't have to put viscoelastic below. You can actually have two cannulas, and you can go ahead and redial. Raised IOP post ICL, the rate has been reported to be 0.8 to 26.2. So you have to actually look at all these things, and prevention is better. So in prevention, washing the viscoelastic is the key. Do not leave behind viscoelastic. That is the key, and do not overinflate the entire eye so that it's very tense, but it should be proper. The pressure should be proper at the end. Factors that predispose the eye to high IOP is the position of the ICL in the ciliary sulcus. If there is a lot of manipulation, you can have a lot of pigment dispersal, and this pigment dispersal can actually cause increase in the intraocular pressure. Vaulting has to be proper, and all these eyes with high myopia, as it is, you can know that they are at a risk of steroid-induced glaucoma. Pupillary block glaucoma does not happen nowadays to that extent, or it does not because there is a central hole which is 300 microns. Otherwise, a prophylactic peripheral iridotomy, whether by a laser or a surgical iridotomy is required. Now, this you can see the pressure would be very high. This is an OCT image. This is an inverted ICL. So if you are putting it upside down, you guys can make it out? So this is a lens which has been put upside down. The surgeon should have known at the time, because the markers of the holes should be right leading, as he was saying in the ICL. Each individual lens has its own markings. So please be careful. Sometimes it can be left leading, sometimes right leading. So which lens you are using, accordingly you should have a marking. And the OCT will clearly show you why the pressure is raised. Now this is intraoperative. I'm just showing you. The problem here is the ICL is going in pretty well. And as you see, you are sticking a little bit of it here. So what happens is that watch the front, do not go below the iris, because you can have a manipulation. This is something that you could see that the lens was going to open the other way around, so you have just manipulated it and put it back. So that is important. When the lens is opening, either you pull out the lens, or at that particular time put in viscoelastic, or you try to avert it at that. Otherwise, even if it opens, otherwise you have to pull it out. Retained viscoelastic, AC overfill, pigment dispersal, these are something important. Pre-existing juvenile open-angle glaucoma, sometimes there could be very rarely a malignant glaucoma has been described. Steroid response is different, and you have to give anti-glaucoma. Now this is typically the OCT that you can see. This is about 859 volt, so this is a high volt that is there. Normally when there is a high volt, I don't mind waiting for some time. It tends to settle down and the pressure does not increase. So just watch this patient very carefully for pressure. Apart from that, a high volt, even at 1000 at times, doesn't cause much of a problem. So friends, these are some of the things that you have to note in the immediate post-op or during the surgical period. And post-op as regards cataract, removing the cataract is not a very difficult thing. Overall, I would rather go in to have a cataract rather than an ectasia. So it's much easier to treat a cataract rather than treating an ectasia. So as Partha was saying, when we started the laser, I have treated up to -18 with my Summit laser. It was a broad beam laser. You must have also treated higher. So Ram, so the early...
My mother-in-law is -13.5.
Great. So the patient is still doing well, the -18 patient. So, but the point is that since these are better techniques that are available, and all of you can do even if you don't have an excimer laser or you don't have a Kalex machine. So that's something important. And I think in Germany, legally, you can't do more than -8 ablation for an excimer laser. What we normally keep is about -8 to -10 is what we are keeping. And that's the thing that we have. You have the Viva now. Indian lenses are also giving. That is a presbyopic kind of a lens that is available, so you can look at that. So this is my procedure of choice. for high powers. Also, when corneas are thin or formifustae or certain other things, keratoconus patients, after cross-linking with stability in the cornea, if they are improving with glasses, you can go ahead and put an ICL. And newer models will increase the surgical ease and reduce the cost to the patient. So that's all that I have to say. Thank you very much for your kind listening. Thank you.
Thank you. Thank you. May I request Dr. Ramamurthy for his talk on challenging situations of phakic IOL? So,
Yeah.
Yeah.
Kamal wants to say
any
something.
question? One.
There.
Dr. Maipal, I have 4 cases like what you reported. And then I actually went back to the drawing board. There's a very important thing called the clear lens right. If the CLR is in minus, even if you have a good vault, the lens will.
Yeah.
So 4 cases I had a patient, I explanted, put in another one, got a vault of 900, but still the lens rotated.
So crystalline lens rise should be
So the
checked.
crystalline lens rise we described 3.5 years ago is the crux. If your CLR is in the minus,
We have
200 microns.
mentioned it in our pre-operative workup.
So
That is
if your CLR is on the minus, then it may rotate. Whatever is the vault. कुछ नहीं सर ये fail होते होते. हाँ निकालना ही है सर.
So, thank you.
But again, I think one thing that is very important, because you know the number of hands that went up, people who are doing ICLs and IPCLs, I mean the phakic IOLs, were less. So please be assured that whatever Dr. Maipal has shown, far and in between, and they are not complications that can devastate the eye. So it is something that is very doable, rectifiable, and so please start doing ICLs. or
Whatever
IPCLs.
happens, they are pardoned. They are not, they are reversible and we can correct it.
Siddharth.
Unlike the ectasia and corneal opacification, endothelial loss, which are seen with other things.
Siddharth, yes.
Yeah.
I recently started doing phakic IOL. I still have trouble with white measurement. Can you give some tips to be exactly accurate with the white measurements so that I cannot go wrong? I have to collaborate with Pentacam readings so that I can get it right.
So basically IOL Master 700 is one value that you take, and from the IOL 700 value to the caliper value is a difference of 0.5. So that has to be adhered to, and both the eyes should be similar, should not be way out. And if that is there, then you are more or less sure, but the caliper value is what is accepted by the...
Sorry, you are using digital caliper?
Yes, digital calibration.
So,
No, when you take under the,
and you have to calibrate it before you start using
Yes,
it.
yes. But I
And
have
they-
little trouble, limbus anatomy.
yeah, when you
Sometimes
take the,
because of the
see it under
arcus
the
or
microscope.
something, you get. I think we should proceed with the talk, we can discuss it.
Though the most important fact will be that you are measuring white to white and not black to black. So you go just beyond black to black, which is white to white. That is the ideal. Okay.
no, I think that's an important question, you know, where people go
Very
wrong.
practical question.
Basically, you have to anesthetize the cornea and take it under an operating microscope. Limbus itself is a zone. So you take from mid-limbus to mid-limbus, where there's a merger of the white and the gray areas, and then compare it with a measurement from a topolizer or an op scan, which will also, if it corroborates and if in both eyes it's nearly the same, it'll work well. Anyway, thank you. I'll be talking about challenging situations with phakic intraocular lenses. And I'm just going to show you the way I do the surgery, because it's a little different from what was shown earlier. And this is almost an unedited video, and you can see that it just lasts about 2 minutes or 1.5 minutes for doing the surgery. I don't dilate my pupils before the surgery simply because all of us had the experience that sometimes when you are doing your side port or main port incision cataract surgery, you touch the anterior capsule. And if that happens, you include that in your excess. But here, obviously, that's the end of the case in case you damage the lens capsule. So I like to have the pupil undilated during these surgeries. And this is the side port which is made up at 90 degrees and 180 degrees. I'm seated temporally. And once I do this, this is only saline I'm injecting, essentially to bloat up the eye. And then so now it's a 3 millimeter central incision that I'm doing temporally. And now when I introduce a mixture of phenylephrine and xylocaine, the pupil dilates very well in these young myopes. And that's actually cohesive viscoelastic that is going in, and you can see that the pupil dilates very well with this, and there's no pre-operative dilatation that is necessary. And the iris coverage of the lens capsule is something that I've got used to in the last 3 to 4 years. And instead of HPMC, what I use is cohesive viscoelastic like Helon. So as you can see, this is an absolutely unedited video, and this is a real-time video, and this is all it takes. And once you, basically I like to do the incisions of the limbus. No IA is used, but all I do is to hydrate my main port and side port incisions, and you can see that cohesive viscoelastic flowing out. Once clear fluid starts, because as Partha mentioned, it comes out as a bolus, and once clear fluid comes, that means at the end of surgery. And all you do is to just go ahead and inflate the main port and the side ports, and in case it's toric intraocular lens, align the lens properly, and it works well. And I suggest that maybe you can consider these 2 tips: not to dilate the pupils beforehand, and secondly to use cohesive viscoelastic, which was not originally taught. And usually you end up with optimal results, like was shown by the earlier speakers also. 500 microns of wall, 250 to 750, a well-centered lens with excellent results. And let us look at rotation of phakic intraocular lenses. When will rotation of these phakic intraocular lenses help? Is only situation is when the spherical equivalent of the residual error is almost 0. If you have -1 diopter with +2 diopters of cylinder, rotation is going to help, because the spherical equivalent of the cylinder balances out the sphere as such. Because when you are rotating the lens, you are not, you are only redistributing the power, you are not introducing any power. So essentially, if it's just a -1.5 diopters of cylinder that's left over, or if it's a 2 diopters of sphere that's left over, then rotation is not going to help. Either you have to do a touch-up on the cornea, or you have to exchange the lens, because this lens is not the right lens that has been placed. So as far as the rotation itself is concerned, do not hesitate. As you can see from a Varion marking, it's rotated by almost 17 degrees. All I do is no viscoelastic it introduced. It's just an irrigation cannula that goes in, and then with through the other side port, which can be opened up. Usually I do it as soon as it is noticed. You just have to gently nudge the lens into the right axis. And it's important that with these expensive technologies, you get the optimal outcomes as far as your patients is concerned. It's again a couple of minutes procedure, and just in case the results are suboptimal and the spherical equivalent is almost 0, do not hesitate to rotate these lenses. Low Walton cataract, as you can see here, it's an eye with just about 130 microns of wall. The fellow eye has just 84 microns, but as you can see, the anterior capsule is absolutely pristine. I have quite a few eyes which have a low walt like this, but where the anterior capsule has been pristine, with the central flow especially, the propensity for development of cataract is quite low. And these cases can be followed up, and no need to rush into a lens exchange just because the walt is low, even though the ideal walt is 250 or more, and that's what you should be aiming at. And when you develop a cataract, Maipal had already shown this, it's most often an anterior subcapsular cataract that you have. So extremely important that you strain the capsules, because the anterior subcapsule is fibrotic. And you can explant the lens. This is running at double the speed. And by doing a hand maneuver, bring one of the haptics outside, then simply through the same 3 millimeter or 2.8 millimeter incision, you can get the lens out. The only challenge here is to do an adequate capsular excess. And here, because most often these are highly myopic eyes, you need a good overlap of the lens optic over the excess. Otherwise, the IOL power calculation itself is no different from what you will conventionally do. And this is a case of an extremely high walt. As you can see here, it's almost 1.4 millimeters is the walt, and 1.2 millimeters is the AC depth. Even more importantly, the angles are just about 12 degrees. Obviously, this angle is going to get zipped up if I do not do something about it. And the fellow eye of the same patient, here again, both these eyes were keratoconus patients, and now it's considered, it's not off-label, but it's an approved indication. You can see here again, the angle is just about 13 degrees, and the walt is too high, somewhat less than the other eye, but still quite unacceptable. So essentially, why this happens sometimes in the case of keratoconus is because if you have a central steepening like this, you can get as much as 4 millimeter anterior chamber depth. And the white-to-white measurements along, according to the algorithm, is not only the white-to-white which measures the sizing of the lens, but also the AC depth. And when you have a normal cornea like this, but you have a central steepening in a keratoconus like this, you can get false values, because of which your phakic intraocular lenses may be oversized, causing a crowding over here. So whenever you are doing in a keratectasia or a keratoconus case, then it's always a good idea to undersize your lenses by 1 or 2 steps. If it's an Indian lens, by 2 steps, because it's 0.25 millimeters each step. If it's a ICL, then it's 1 step because it's 0.5 millimeters. Once we have started doing this, we find that this kind of oversizing with keratoconus cases is not there. And what did I do for that particular case that I showed you? Basically, exactly the same thing as the case with the cataract. It's extremely important that you do this exchange as quickly as possible, because if such a high vault is left as such, then you could end up with a zipping of the capsule, onset of glaucoma, which is a very difficult problem to treat subsequently, much worse than developing a cataract. Both the eyes of the same patient was actually exchanged in one sitting with a 0.5 millimeter less sizing, and it worked out well as far as the vault is concerned. And toric phakic IOL in corneal ectasias, this is a challenging situation. Initially, it was thought to be off-label, but whenever you find that with spectacles, you are able to get a good correction. You can have a centered cone. And how do you know it's a centered cone? You look at the posterior float. If the more than 50% of the cone is within the central 3 millimeters, or it's a very well-centered bow tie, then these are the patients who will do well. Just in case the patient needs a contact lens for the improvement of his keratoconus or the ectatic condition, these are not appropriate, rose scale lens or a scleral contact lens, because what the phakic intraocular lenses will do is what the spectacles will do. It is not going to take care of the higher order aberrations. So essentially, we have to make sure that the patient has a well-centered cone as well as a good improvement in the visual acuity with spectacle correction. These are the ideal patients as far as phakic intraocular lens is concerned. You can see this patient would have undergone an intact procedure with cross-linking, and subsequently for visual rehabilitation is undergoing a phakic intraocular lens implantation. This is an excellent way of, you do the cross-linking to stabilize the cornea, put the intacts to center the cone. Thirdly, you put the phakic intraocular lens to rehabilitate the eye. And you can see a situation like this, again, where the cone is decentered. Because it's somewhat less, what I do is to do a topo-guided PRK. You can see the best corrected visual acuity is only 618. But once I do a topo-guided PRK, not only does it get centered, but the visual acuity also improves. And obviously a good candidate for this. And here again, 612 vision, pre-CXL intacs, post-CXL in intacs, you see that the amount of astigmatism has increased, but then the best corrected visual acuity has come to 6.9. So obviously a good candidate for doing the surgery. And just in case this is a post-DALK phakic intraocular lens, sometimes post-PK, post-DALK, you have a high astigmatism, even though the cornea is quite clear. And especially in a PK case, you have to be cognizant of the fact that the corneal endothelial cell count might be somewhat lower, but then you can rehabilitate these cases by putting a phakic intraocular lens. Last of my videos, and this is just to say that Partha and myself went to first started out these iris clip phakic intraocular lenses, and this is a patient who basically had an excellent visual outcome, was not willing to give that up, but the endothelial cell count has dropped down to less than 1,500. So essentially what I'm doing in this case is to remove this phakic iris clip lens, which is essentially a 5 millimeter overall diameter lens, and it's a PMMA lens. So I'm doing the 2 surgeries 1 week apart, taking the iris clip lens out, but since she was not willing to forsake the excellent visual outcome, I'm going ahead and implanting a conventional posterior chamber phakic intraocular lens. Thank you so much for your
Thank
attention.
you, Dr. Ramurthy. May I request Dr. Bharti for his talk on long-term results, and after this, our another star performer and star instructor, Dr. J.S. Titial, will be is with us.
Hi, slides, please.
And yeah.
So, Dr. Ramurthy
slides.
and myself went to Professor Burkhard Dick. Burkhard Dick is here in person, and he's one of our guests this time. He's come, and please be sure to attend his sessions. He's a great innovator and very good cataract surgeon. And
Delhi was nearer, na? You could have come to us, Bharti and me.
One important thing is that we should not constrict the pupil intraoperatively at the end of the procedure, because earlier it was thought that we should constrict the pupil at near the end. So that should be avoided. That should not be done, because that will not release the viscoelastic from behind the lens. If the pupil remains dilated, so viscoelastic which is present behind the lens will come and mix with the aqueous, and it will not lead to the rise in intraocular pressure and the development of the cataract.
any
See,
other
things
questions
have-
from the floor?
Things have changed because earlier I used to do a surgical iridotomy. So that is why you needed a small pupil to do a surgical iridotomy. The other biggest advantage is that if you leave the pupil dilated, then post-op, immediate post-op, before the patient goes, you can actually see the alignment. If it is small, you can't see the alignment, but you can see the alignment, that the alignment is fine, say 45 minutes or 1 hour. So if normally, majority of the rotations occur in the first few hours.
Thank you.
Good morning, friends.
Front row is available. Come and sit in the front row.
You can come and sit.
I'll be talking on long-term results and issues of the ICL. Majority of the talk has been covered by all the speakers. As you know, they have given you all the indications, contraindications and complications. So this is regarding the EVO ICL, is a single piece posterior chamber lens. I'll be talking only about EVO, and as a single central fenestration, and this allows the flow of aqueous from behind the ICL, allowing the normal physiology of the eye. And this is the small video which is hardly 30-40 seconds just for the implantation of the ICL. This is the side port. The idea is not to go beyond iris if it is a dilated pupil. Put a little bit of anesthetic, 1% xylocaine. Put the viscoelastic to the extent that you can continue to see the chains of the viscoelastic and not overfill the chamber. Make the main port once you have put the viscoelastic in, so that you do not inadvertently injure the anterior capsule. And then what I do is I put a little bit of viscoelastic on the mouth of the bottle, and this way this viscoelastic takes care of the ICL. It does not fall. And then this is just to hold the ICL and pull the cartridge back, and not pull the ICL into the snout and then inject it. Everyone has seen it opens very peacefully into the anterior chamber. Do not try to push it behind the iris initially, and then dial it, gently press it and dial at the desired position. But first of all, push the posterior lip so that all the viscoelastic comes out from behind the ICL, and then put the viscoelastic in front of the ICL to push it back. So that way, majority of the viscoelastic you're trying, it was there in the eye, from behind the ICL is out. So there is not much need to wash. Of course, you need to wash, but not that much as if you have left it behind the ICL. So these are a couple of tips to put visco on the mouth of the bottle, and take the viscoelastic from behind the ICL. And then just put the flow of the irrigation on the fenestration, and immediately the whole viscoelastic comes out. So the issue is, mainly the issue are sizing and the vault, and ICL is directly related to the vault. So if sizing is good, vault is good, otherwise it is not good at all. Excessive vault causes pupillary block, endothelial cell loss, pigment dispersion, and also the problem is the corneal uh, 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 corneal opacification at the area where the vault is extra and it is touching the endothelium, and insufficient vault causes the cataract. Appropriate overall diameter, and the more important thing is whether you are measuring sulcus to sulcus or white to white. No methodology has proven superior to white to white. Base sizing in the terms of predictability of vault and sizing based on white to white and ACD remains the most popular and the best suited technique. Long-term data now available from a post-approval study of the implantable columnar lens for myopia conducted under US FDA has provided additional information on safety and incidence of cataract, elevated IOP, and endothelial cell loss. And the MICL passed the incidence of anterior subcapsular cataract was studied in 526 eyes of 294 patients, and 31 eyes out of these 526 developed ASC, and 5 of these eyes developed visually significant ASC. In my own series, where I might have implanted something like around 10,000 ICLs over a period of 24 years, I have had 2 significant cataracts and 1 was operated. In regard to the incidence of cataract, old age and higher level of myopia represent risk factor. Thus, patient selection can reduce the risk. Central port helps to maintain the health of the crystalline lens by allowing physiological flow, and no visually significant cataract is observed in EVO ICL over a period of 5 years in the studies which are shown. And elevated IOP was observed in 17 out of 526 eyes, 3.2% due to pupillary block, and it can be controlled immediately with eye iridotomy. So that's another factor. Despite the fact that in EVO ICL there is a central fenestration, you might need to do a eye iridotomy if there is an elevated IOP because of the viscoelastic or other reasons. A retained viscoelastic causing increased IOP in the immediate post-op period either resolved or with irrigation but as soon as possible. Endothelial cell loss, 144 eyes implanted with ICL from 1998 to 2001. Initial 6.46 decrease in ECD in the first year and annual decrease of 1% every year. So expected age-related loss of endothelial cell density, which is 0.6% per year, otherwise also because of the age. So no cases of corneal decomposition in the absence of trauma has been reported following ICL implantation. Fluid dynamics, there are negligible optical effects of the central hole. Sometimes in the initial phase the patient complains, but majority of times when you tell them that it is because of central fenestration will go away over a period of time, they accept it, and majority of them, kind of do not see them for a long time. So effectiveness is post-operative uncorrected visual acuity, refractive predictability, and stability after 12 months is absolutely fantastic. Efficacy index of 1.04% and correction of within 0.5 diopter in nearly 91% of the patient. Corrected distant visual acuity, only 0.2% of the eye lost 2 or more lines of CDA, while 95.5% maintained or gained lines primarily because of the better optical quality, because no corneal procedure has been done. Transient IOP rise, no eyes had elevated IOP after 1 month, so this is pretty safe on that. And cell density, I have already talked about it, that their mean percentage of endothelial cell loss 5 years post-operatively was 0.5% plus minus 5. So that's very decent and hardly any loss of cell density because of the ICL. It is related to the aging also. So they can provide optically superb correction of relatively high degree of ametropia that lies well beyond the recommended range of keratorefractive procedures, high level of post-operative uncorrected visual acuity, and predictability and stability demonstrate the effectiveness of the EVO ICL. Safety data suggests reduced rate of ASC cataract and pupillary block and improved safety and effectiveness across the board. Range of refractive error make EVO as an attractive option for surgeons and patients. Thank you very much.
Thank you. May I request Dr. Titial sir for sharing his experiences of presbyopic phakic lenses.
Thank you. Good morning, friends. Thank you, Purin, for getting me into this wonderful course. I thought I'll share my experience with presbyopic phakic IOLs, which you all understand. We have a large range of people who requires presbyopic correction, and that is a very significant number. And it's going to be a future challenge for all of us to manage these patients. And almost 1.8 billion people globally are presbyopic. You can understand what a huge market we have, and nothing concrete till yet which can be a good solution for these patients also. These are very surgical options for tackling presbyopia in this age group, and I'm going to talk about presbyopic phakic IOLs, because this is one concept we have taken up from the ICL star, which has been there for more than 2 decades. And subsequently, so many ICLs or phakic IOLs have done such a good results for a myopic patient, hyperopic patient in a younger group. So I thought let's try these in a group of patients with a presbyopic. We have 2 lenses available, one from Star Evo Viva, which is EDOF ICL, and one is IPCL, which I've been using for the last 6-7 years, a hybrid hydrophilic acrylic refractive diffractive design like this, and which gives you a large range of correction from +15 to -30 diopters, huge cylindrical correction. And most importantly, you can customize the diameter 6.6 to 7.5 millimeter depending on the pupil size. Because pupil is one dimension which makes a difference in all these phakic IOLs. With the overall diameter range can also be changed. So you can really customize these lenses, and it also has a center opening which also decreases the intraocular pressure related changes also. You require a good, you can say, pre-op investigations like you do for all phakic IOLs. Same thing is here. And predictable bolt is again same, 250 to 750 microns after surgery. Make sure patient is, good counseling has been done, because that is one thing which is required for all refractive surgery. And this is required more for a presbyopic patient as such. Let me just show you one of the surgery here. This is a toric IPCL presbyopic lens being done. You have to have a good marking done. Axis is normally 180 degree for these cases. I normally use viscoelastic for these cases, and my preferred choice has been a sodium hyaluronate 1%. And this loading of lens, you should always read the instruction from the company how to put these lenses, because the angulation has to be different. Normally I take, these 2 holes which are there should be towards your right hand side if you are doing a right eye surgery, towards the left hand side if you are doing a left eye surgery. So once you put it there, it's an open cartilage. Make sure lens is free, because otherwise it gets stuck into the cartilage and you can break the lens. And you can inject the lens subsequently, like you do for any other lens. It opens very slowly. Make sure these 2 holes are towards the lid side. That's the right configuration. If that is not happening, you can pull out the lens at that time only. And surgery is very, very simple. You can fix the lens in a toric area, remove the viscoelastic completely from the anterior side. And this hole gives you access for aspiration of viscoelastic also. Overall advantage, you all know phakic IOL is, this is the surgery which retains the patient's accommodation. Therefore, the age group which is suitable is from 45 to around 58, which is a suitable age group for a presbyopic implantation IPCL. It's a reversible procedure, 40 to 60, ACD more than 3. This is a routine things. Pre-op work is similar as we do for all these things. The addition required for is a -0.5 diopter to the spectacle correction for presbyopic correction which patient requires. To just give you an example, one of my patient, 43-year-old male patient, -6. All high refractive error patients are good candidates. Never do for a low myopic patients, and emmetropic patients are a difficult choice. Hyperopics are always suitable cases. So this is the ACD of 3.2 millimeter and OCT. The corneal profile is absolutely normal, and if you look into the value of DLI, which is also normal in this case, 10, and DLI is normally I do for all cases, which is very, very effective way to counsel your patient. Lens is absolutely clear. You can see the point sort function is also very good, and this patient did well. This is a second patient where you can see the DLI is decreased. You can see 2.65. So this is not a suitable patient for a presbyopic IPCL. In fact, any intraocular surgery. This case may be suitable for a presbyopic cataract surgery, where you can use presbyopic IOL as such. So this is a 3-year results of my cases with a very good outcome for uncorrected distance acuity, intermediate and near vision in all these cases, very effective lens. The only problem can be around 5 to 10% of my series of cases do complain of halos and glare and a difficulty night driving sometimes. So that has to be explained to these patients as such. This is one of the long-term results published in literature where they looked into a concept of a presbyopic IPCL, 6-month follow-up. My follow-up is now 6 years. The cataract formation can be there in these cases, like this one of my patient developed cataract, and the cataract can be tackled very effectively also. So this was 1 month after the IPCL, everything was all right, and this is subsequently the patient came later after 1 year. You can see raised internal aberration for this patient because of cataract formation, and surgery could be done very effectively also. You can explant this lens and do a surgery through a 2.2 millimeter because this lens can come out from 2.2 millimeter. I could do Rexus and implanted multifocal lens for this patient subsequently, and patient did very well. You can see multifocal lens 6, 6, and 6. So this is the advantage of surgeons who are practicing this. You can induce cataract and do surgery subsequently and double from these patients. But counseling has to be done very effectively. The chances of cataract formation in my series has been around 1% in 3 years. To summarize, presbyopic phakic IOLs are a good option if patient is willing for this intraocular surgery and gives a very acceptable distance, intermediate, near vision for these patients. The only consideration is, if the pupillary shape changes, then the patient can have a difficulty of glare and halos. If your pupil is normal size, the patient is quite comfortable as such. Little bit of contrast changes can be there that can be managed by increasing the reading light for these patients also. But long-term results has to be seen, what happens to your patient after 5, 10 years, because they are going to come to age where cataract formation is going to be there. If you have a myopic patient, the SS has a nuclear sclerosis, which may get enhanced by this procedure. So that has to be explained to this patient. If you have access to eye trace type of device, do a serial DLI, and that could give you indication if surgery for cataract is required or not required. Thank you for your kind listening. These are our books. You can go through them. Thank you.
Thank you, sir. Any quick question? And in the meantime, I will invite Dr. Kamal Kapoor for his guest talk, the magnificent, versatile EDOF. And Kamal, any question? Quick one question. Sir, one picture we can take.
So meanwhile, sir sets up, I would like to add a small addition to Dr. Biswas's presentation regarding the loading. So the ICL cartridge has this small extension which we use for locking it into the injector. So that's a very good landmark for aligning the holes on the ICL, because many a times while pulling the ICL tends to get rotated. So that helps in.
A very, very good morning to everybody. I think I'll stick out like a sore thumb in this phakic lens session. I'll be talking about an IOL, but maybe a little bit of leaf from my seniors and stalwarts in this. I remember 1999, Dr. Mahipal did the first ICL, and I, like a trailblazer, followed him, and I did my next one after him, and I've never been looking back. Just 4 points from the previous session are, for people who don't have fancy equipment like IOL Masters or Cirrus or Pentacam, your good auto-refractokeratometer with good imaging system can serve very well. I probably have the highest volume of phakic lenses in this part of the world, 6,000 plus. And I have patients operating in 18 of my centers. Not all have these equipments, and we are doing very well. So basic point is have an autorefractor keratometer, use the pupillary marker, and have two optometrists do an independent data. Don't let anybody look at each other's data, and we'll get a fairly very accurate. For my practice, I use a caliper only to confirm, not as the primary. Number two, when you're operating a keratoconus patient, this can be very, very tricky. Look for an angle more than 45 in case you're planning a high vault. When you're doing a toric patient, plan a higher vault, because if this lens rotates, you could be in trouble. A monofocal lens, if it rotates, doesn't matter. If your lens has rotated more than 30 degrees, explant it. No use redialing it again, it'll again rotate. So little practical points. Now coming to my topic. So I'll be talking about the EDOFs. I am a fan of EDOFs. I was probably one of the highest multifocal users in this part of the world. I've switched nearly 100% to EDOF lenses. This is one of the current lenses which I use. I have no financial relationship here. Is it the holy grail? Presbyopia correction after cataract surgery, is it the holy grail? And are the EDOF lenses the missing link of correcting presbyopia? And I call it iatrogenic presbyopia, because as the doctor, actually, especially in a myopic patient who's creating the presbyopia, the patient didn't have a presbyopia before that. So are EDOFs so we'll be looking at a lot of it. This could actually be this is a part of my instruction course. I'm cutting the slides. For people, beginners who want to move into phakic IOL practice, I have an instruction course tomorrow at Brahma Kamal Hall, 2:45, how to start a phakic IOL practice for beginners if you don't have a fancy machine equipment. So you have four kinds of presbyopic correcting lenses: multifocal lenses, enhanced monofocals, EDOFs, pinhole lenses, and accommodative lenses. Basic principles are the diffraction, refraction, and pinhole. These are the three principles most of these lenses will work on. Either it will be a combination of them or one of them. So multifocals, we know, create a discrete point of focus, and there is a zone of defocus. So that is a big problem with multifocals, at least in my practice. I was doing 200, 250 plus multifocals a month, but the chair time was eating my head, because the amount of chair time I had to spend with the patient before, otherwise I was spending 10 times more after the surgery. So I was looking for an alternative which would probably give me a free hand and able to do more and more, the lens being more versatile. So this is how a monofocal lens will be actually. Can I have a pointer, please? Okay, let's work with this. A monofocal will have a single point of focus, a diffractive bifocal will have two points of focus, and a trifocal will have 3 points of focus. How do EDOFs work? EDOFs actually work by creating a long tunnel of field of vision. They do not have a single point focus, but they have a diffuse point of focus stretched over a little distance. So when the patient tries to bring the object closer, they'll raise the more diffractive, and the negatively spherical aberrated lens actually creates that tunnel of focus and defocus. So patients have excellent intermediate vision. The only issue with the EDOF was it was not giving you a good near vision. But let's face it, in our day-to-day lives, our mobile phones, our laptops, eating food is intermediate. Gone are the days when you're lying down and reading a book. Until unless you're hiding your chat from your wife and working on the phone like that, or your husband. So we're not using the phone so close now. So what an EDOF does is it creates a longer zone of focus. It's like a funnel. It funnels the light and gives you a longer travel distance. And the American National Standard Institute actually has given a very vague definition of EDOF. There's still not a very standard definition. What it says is more than 50% of your patients should be N9 or better with full distance correction. So the lens should be having a little bit of myopic shift by more than 0.5, but it should not be underperforming for distance than a monofocal lens. But if you actually look at the definition, it's a very broad definition. So I have used, so this is what a monofocal lens will have an energy distribution in the center. A bifocal or a trifocal will have bumps. You'll have energy distribution in the MTF curve, then one for intermediate, and one for distance, and one for near. What an EDOF does is, it gives you a clear focus for the distance, and as you start getting the object near, you have a longer defocus energy distribution. So you are able to see objects. Why did I stop using multifocals? First of all, the patient is not happy till you operated the second eye. The multifocals are very, very intolerant to residual astigmatism.
Capsular opacification, even slight amount of capsular opacification in multifocal can really trouble the patient. Loss of contrast in multifocals is far more damaging than the EDOF or your monofocal lenses. If the patient, God forbid, has a macular edema, multifocal lens, the patient is probably going to shoot you. Any amount of surface disorder is more unforgiving with a multifocal than with an EDOF. So these are the reasons why I actually started moving away from multifocals. In my practice, most of my lenses, multifocals are being implanted in the patient where I've done a multifocal earlier, and he was happy. Otherwise, I'm not. So multifocals are very, very intolerant to bad pupil sizes, and of course, more chair time. So these are the 8 C's why I'm shifting away from multifocals. The reasons for explantation of multifocals are, the literature is full of them. Most of them are photopic phenomenon, halos, glares, loss of contrast. The literature is full why people are explanting the multifocal lenses. Now let's give you a basic understanding. How does a lens EDOF work? In a positive spherical aberration, the peripheral light rays are focusing in front of the macula. In a negative spherical aberration, they're slightly further away. If you slightly start increasing the negative spherical aberration, you start getting a longer tunnel of focus. So this is the basic concept. So this is called a zone of defocus, but yet there is a lot of light there. But there is a catch here. You cannot indefinitely increase the spherical aberration because then it will start causing a bigger defocus. This is what happens. So most of these lenses will work best for 2+2 diopters of depth. The moment you start going more, you'll have a broader defocus zone, and this will happen. This ring will start getting bigger. So your loss of light is higher. This can large pupil size, you'll have peripheral distortions. This is a photograph I took out of the fisheye lens. So understanding types of technologies, I'll just spend little time there because this slide actually includes Vivity, your Lucidus, Siphy. I've used all these lenses. But I'm just skipping it. So these are broad categories of lenses, which are types of lenses. Some of them are hybrid, some of them are pure EDOF, some of them are enhanced monofocal lenses. Energy distribution, as I did explain, EDOF has a longer energy distribution, so the loss of contrast is less. You have more depth, but yes, it will not work for near. I've done more than 6,000 of these magnification lenses. I'm fairly satisfied. I'll just share my data. 68% of my patients are N9 or better, and they say they don't need glasses at any point of the day in their day-to-day routine, which is far better than the 50% data recommended by the American Society. So 6/6 and N/6, 68% were in the standard deviation main curve. Least amount of photic phenomenon and glares reported with the enhanced monofocal category. This is how the lens probably works. Central 3 mm zone is giving you a near add of 1.75, which is a fairly good distance appreciation. Preoperative chair time, you need to tell the patient that you are not going to see very good for near. You need to emphasize that because patients will always listen that you're referring to near, but you're referring to intermediate. So what I do is when I explain it to the patient, I do the hand action. The lens will work at this distance. So I make the patient repeat. How far will the lens work? So once they've actually memorized it, they will not come back to you and complain, oh, it doesn't work here, because you made them enact the whole thing. So first question I ask the patient is near vision more important to you, or can you live with glare and halos and not being able to drive at night? Guess what? 92% patient says, I'm happy with intermediate, I don't want glares. That settles the matter for you. This patient is never going to complain for a bad near vision. So most are okay. I'll just jump here. So what are you going to look for when you're planning EDOF lens is Q values, surface disorders, astigmatism correction, you have toric lenses available, good macula, no surface disorders. So I think that's it. So thank you.
Thank you, Dr. Kamal, for the excellent presentation. So now I invite the chairpersons for the next course.